Thank you, sir. Thank you, Kumarvel sir, Aruna ma'am, for inviting me for this wonderful session. So, as sir had mentioned, I am the opening batsman as well for the speakers side. So when we see any conference, the menu is always the agenda. And when I saw my topic, I was like, what it could be meaning and what should I deliver at the end. So when we think of any topics or any conferences, when you see some topics like this, always we feel that we are going to learn some basics out of from the very start of it. So this particular topic is hypothyroidism always lifelong. Quite challenging, but it is always very practical. So when we see in any practice, any type of practitioners, you can be dentist, you can be any form of practitioner, GP, anyone. So thyroid disorders are going to be the most common after sugars. These are the most commonly done investigations in the day-to-day practice. So it is always a myth and always a problem when we start facing these kind of scenarios, whether should I treat and should I not treat, should I refer, and what to do when I follow it up. So patients may not come with symptoms, but it is always like the interpretation which is going to be the problem what we face in the reality. So I will try to break some of the myths and see some of the data at the end. We will try to conclude which are the patients who requires treatment and who are supposed to be followed up. So these are the common causes of hypothyroidism. You can label, so Hashimoto's is the most common cause of hypothyroidism when you take more than 3 years of age, and congenital hypothyroidism is the common cause for age between neonates to 3 years. And the Hashimoto's accounts for almost 80 to 90% of cases. Rest of the things will be the other accounting for say 20 to 30% of cases. Thyroiditis, of course, it's rampantly increasing the day-to-day practice, and this is basically due to secondary infections. It could be due to other conditions which can cause the inflammation in the thyroid. And the secondary causes, of course, these are all very rare, but we need to know some of the practical points when to recognize these hypothyroidism. So the whole idea is about whether are we seeing hypothyroidism as always permanent. The answer is the hypothyroidism is not always permanent. That is the fact that we are going to discuss today. So I will start with the case. This is a 13-year-old chap who was referred to me with ADHD, that's autistic hyperactivity disorder. The patient actually, over the last 2 months, the mother told me that the child had started sleeping more, and the child is a bit of lethargy in the overall activity. Schooling performance was a bit on the poorer side. So based on the previous photographs, when we saw the child actually had some amount of thyroid swelling, which was really missed over 2 to 3 months duration, and we could see that the course of the disease over months together. So he was referred to us, and we can see the height of the child is around the lower side, 36 centile for the age, and the weight is approximately normal. The child had a grade 3 goiter. Sorry for the photograph. It was a grade 3 goiter, that is same. So we can see the goiter when the child is able to having the neck extended. We can see the goiter there, and the goiter was firm and non-tender. So because there was no tenderness, the mother didn't worry about the swelling as well. So lab showed that the TSH was elevated. So we can see the value of 5.5, it is 416. T4 low and T3 is also low. That is a classical primary hypothyroidism, what we face in the day-to-day practice. So this particular chap is actually missed out a case of primary hypothyroidism. The complete blood count was done normal. Ultrasound showed an autoimmune thyroiditis, and the TPO antibodies was negative. So 4.5 is actually negative. If it's more than 3 times elevation of the upper limit is considered to be again positive. And the child was evaluated further. The urine iodine was done because the child had a negative antibody. So urine iodine was done because the child was autistic and the child's food behaviors were actually abnormal. Mother was feeding with the rock salt, and when you go back regarding the dietary history, the child's feeding habits were very poor, and the urine iodine was done, which showed that it was very low. The normal is 26 to 700, but it's actually 11.5, which actually gave us a clue, and gave the diagnosis of iodine-associated hypothyroidism. Child was started on a low dose of levothyroxine, and the child was placed on multivitamins and other replacements, which child actually improved out. Child's symptomatology improved over 1 to 2 weeks duration, and child was perfectly healthy over 2 months duration. This was a photograph after 2 months. The child actually reversed with the goiter. So this is a case of iodine deficiency, but still we see, though it was actually recognized to be very rare entity, now still after the food faddisms and other things which the mothers and relatives are having about, these are commonly seen in the present day practice. So keep in mind, iodine is very essential for the thyroid hormone production. So moderate cases, there is T3 suppression, but once you have severe cases, there is both suppression of T4, T3 production, and the TSH starts climbing up, and the child will have goiter because of both hypertrophy and hyperplasia of the thyroid gland. So long-standing deficiency actually causes thyroid nodules. That's why we ask the mothers with thyroid nodules, people with thyroid nodule to have iodine to be consumed. So this is a recommended daily iodine intake. So children should have at least 90 microgram. Adults should have 150 microgram per day, and pre-pregnancy 250 microgram per day. So particularly to the concern is actually whether this is a permanent one or it's a temporary one. Definitely, once you start looking into the iodine deficiency, start treating the iodine deficiency, the child's overall the iodine functions, iodine formation, everything, thyroid formation will be improved. So management is initially starting with a mild dose, gradually following up with the dietary addition, and then once the child's thyroid function improves, we can taper off the thyroid. And this is the second case, 75-year-old gentleman who came with worsening limb edema and shortness of birth, and the patient associated the constipation, generalized weakness, daytime sleepiness, and increased urinary frequency. Past history, ischemic heart disease for 5 years, and the patient had atrial fibrillation diagnosed 2 years back, and the patient was placed on amiodarone. So his weight is 78 kgs, BP is on the lower side, there is tachypnea, and there is a palpable thyroid gland again. So the patient had irregular heartbeat and an elevated JVP, which is again telling us about the CCF. Once you have this kind of picture with a palpable gland, always go behind the investigations again. So you look at the routine CCF evaluation, particularly this gentleman had a BNP was negative. That indicates the patient had CCF findings, but the overall CCF is basically not due to the fluid overload. Once we did a thyroid, it was elevated, 93 was the value, and the T4 was actually lower side. Anti-TPO antibody was negative. So on the background of the amiodarone exposure, it's a clinical diagnosis. We put the diagnosis as amiodarone associated hypothyroidism, which is again quite commonly seen in the practice right now. So this is basically because amiodarone is one of the beautiful molecules of antiarrhythmic spectrum, which has 33% of iodine in the drug molecule. And once you load the iodine into any person with some underlying iodine sufficiency, you will have a phenomenon called Wolff-Chaikoff effect, where because of the excess iodine that is coming out, the suppression of the T4 will start happening, and then the TSS will start increasing higher and higher. So these are all going to be seen in areas where you have iodine sufficiency. It's not deficiency, it's sufficiency. So management is basically, if the patient is on amiodarone, if you are able to stop withhold, better do it. If not, then we need to start the patient on small dose of levothyroxine. And we need to be careful in these patients. You need not normalize the TSH as of like any patients what we treat in the day-to-day practice, but always we need to keep it on the low normal value, not to cause thyrotoxicosis, which is again going to be problematic in these patients. If the patient has an underlying autoimmune condition, this particular condition will become permanent. If the ultrasound is normal, then we can give a drug holiday for this particular patients, and then we can take back the, we can stop the levothyroxine therapy also. So that indicates these are all some of the clinical entities, and particularly that gentleman actually had worrying course because we were not able to stop the amiodarone. We had to continue the levothyroxine replacement. As of now, he is under levothyroxine replacement. This is a third case, A neonate was referred to us because the clinician had cord blood was noted to have a TSH on the higher side. Day 4 life, it was repeated. Again, TSH was higher, T4 was low, and T3 was low, and the child was actually evaluated further for neonatal screening for hearing. This is again looked for Pendred syndrome, and that was actually negative. Bilirubin was done, and bilirubin was found to be elevated. Child had some coarse features, facial features. There was mild macroglossia, there was a small umbilical hernia. The baby was referred to us because the TSH was abnormal, and the ultrasound was done initially. It showed a normal thyroid, but actually it was mildly enlarged. Second, because the thyroid was mildly enlarged, we did a per-technet scan, and it showed the uptake around 7.8%, and the follow-up was actually a clinical dysharmonogenesis. This was the per-technet scintigraphy what the child had, and that actually showed that this is a case of dysharmonogenic goiter. And once we did a genetic testing, it showed a DOX2 mutation. This DOX2 mutation is actually, it's an iodine that is being incorporated into the thyroid molecules is defective. But some of the cases in the literature, it's actually showing some of the, giving the data that it's a transient, neonatal hypothyroidism. So this is a case of dysharmonogenesis again. So congenital hypothyroidisms are again on the rise. We find a lot of cases. The number of the cases are around 1 in 4,000. These are all data what we have seen from the textbooks, but once you look into the scenario, even 100 newborns, you'll find that TSH is high for at least say 10 to 15 cases. So most of the cases are, they don't have genetic inheritance, but smaller proportion, they tend to have genetic inheritance. And these are all some of the etiologies of hypothyroidism in nutshell, but though they are cumbersome, we will discuss at the end. The big question is, does the diagnosis of the hypothyroidism going to be lifelong? Whether this particular scenario will require hypothyroidism to be treated for lifelong. Hypothyroidism basically means the gland is underproducing. It does not mean there is actually a disease entity. So we think that hypothyroidism is a disease entity, it's actually a manifestation, where the thyroid is not able to produce sufficient hormones. While most of the cases are permanent, we see a lot of still transient cases in the practice, which requires just follow-up in weeks to months together without any replacement. When it is going to be lifelong? These are common scenarios what we find. Hashimoto's is the most common. Post-radioiodine therapy, where you try to give radioiodine for Graves' disease or radiotherapy for any other cancers in the neck. You tend to destroy the gland. Thyroidectomy, you destroy the gland. Congenital hypothyroidism, where the gland may not be there, which make the children or the adult to have replacement for lifelong. What are the conditions where you have a temporary phase? This is one. The postpartum thyroiditis, where you can have a transient TSH rise over 6 to 8 weeks, and then it resolves over 12 to 18 months. Subacute thyroiditis, where you can have a kind of a viral infection which can trigger the TSH to rise after the phase of viral infection, and then it gradually wanes off over 1 to 2 months. Drug-induced, particularly lithium, amiodarone, and immunotherapies, which again, it's going to have a transient effect when you have a normal thyroid, and once you stop these medications, it will revert back. Iodine imbalance, again, this we had seen from the case scenario also. Subclinical hypothyroidism is a gray zone. Always when you have a TSH between 5 to 10, it is always a gray zone for everybody. So whether to treat or not, because most of the patients will not have any symptoms. Definition by say, they will be having normal T4, T3, but the TSH alone will be mildly high. It's mildly high means it's between 5 to 10, and most of the patients, if they are having a normal appearance thyroid gland, definitely they will resolve over 1 to 2 months duration. Wait and watch is the treatment if they don't have any symptomatology. So monitoring is the key. So whether it is possible to reverse the thyroid, the myth is always the thyroid means it's always permanent. In fact, if the thyroid tissue is destroyed, then it is going to be a permanency. If the thyroid is appearing normal, then it is going to be a reversible phenomenon in the initial phase. So remission can be possible if you are able to see mild cases, say between 5 to 15 or 20, up to 20 is still, if the patient is asymptomatic, you can follow it up and see, or you can treat symptomatically for a short term, and then you can wean off, give a trial of weaning off. So it's a etiological classification. Again, the clinical thing is always look at not only the TSH, look at the T4, T3. If the T4, T3 is normal, then you are in the safer side. If T4, T3 is low, then you are supposed to treat then and there. And look at the symptoms also, because if the patient is having TSH rise and symptomatically they are, having hypothyroidism, definitely you are supposed to treat. If the symptoms are not there, then you can treat. So two things we need to see. One is the T4, T3 values. Second is the symptom of the patient. So this is again some of the inflammatory conditions where you have a transient phase of normalization, but in the follow-up, they may either go for hypothyroidism or they may maintain their euthyroid state. So one is the subacute granulomatous thyroiditis, decurrence disease. Again, we have a lot of infectious thyroiditis which can have a transient phase of hypothyroidism and then they can become improved. And postpartum thyroiditis, which we see a lot of case scenarios, there is a phase of hypothyroidism, they may subtle, they can improve, and then they can worsen with the hypothyroidism in the in the months together on follow-up. So the medication induced, that's what I told you, Ulch-Chaikov effect. The amiodarone, lithium and checkpoint inhibitors are immunotherapies where we use it in the day-to-day practice for a lot of head and neck cancers. Amiodarone is very prone to cause the thyroid dysfunctions. That's why there is a recommendation to follow up the patients with amiodarone usage when you start. Definitely on the starting itself, you are supposed to do a thyroid function. If you are following up over the months, you are supposed to do serial thyroid functions if the patient is on amiodarone. Lithium, again, initially there was a dip in the usage of lithium. Now we are seeing a lot of patients with placed on lithium from a psychiatric point of view. And when you are placing the patient on lithium, definitely again serially monitoring 3 to 6 months with thyroid function needs to be done and requires, if the patient is having an goiter, definitely ultrasound should be done in any patients with lithium exposure. So what are the diagnostic things we need to do? First and foremost thing is always ultrasound. Ultrasound will tell you whether the gland is normal or not. If gland is enlarged, if the gland is having the Swiss cheese pattern where you have the thyroiditis picture, definitely there is an underlying thyroid destruction which requires the patient to be placed on long-term thyroid function. Second is thyroid scintigraphy, where you can do a petachnate scan. You can look at how much thyroid is having an uptake. If that thyroid uptake is high, normal, then it is going to be a transient phase of disease. If the thyroid uptake is low, definitely the hypothyroidism is going to be permanent. Fourth is the anti-TPO antibodies. Again, this is a marker. Additionally, we do a thyroglobulin. These two will tell you regarding the destruction. So if the TPO antibodies are higher the antibody titer, higher the chances that the patient is going to have a permanency rather than going for a transiency. So trial of withdrawal, if the patient's thyroid function is between 5 to 20, if the patient is asymptomatic with a normal T4, T3, definitely you can give a trial of withdrawal after starting a small dose, and then you can stop for some time looking at whether the T4, T3 is reversing. TSH is reversing back to higher level. So the clinical management is always thyroid hormone replacement. If the patient is definitely noted to have permanent disease, definitely you need to replace with levothyroxine therapy. So transient diseases, definitely even in cases with autoimmune diseases, if they have a transient euthyroidism, you can stop the therapy and we can wait for the worsening of the thyroid dysfunction. So short-term levothyroxine therapy with a smaller dose, not the usual dose of 1.6 microgram, usually between 25 to 50 is the maximum dose we give for a transient hypothyroidism in adults. Prognosis always, if they have transient, that does not mean the thyroid will go off. It means there is a phase you can have a euthyroidism, and then it can have a phase where you can have a rebound hypothyroidism. That is why you are supposed to do every 3 to 6 months of their thyroid function after stopping the thyroid hormone. So just to bring it to a nutshell, these are the common the causes of the transient hypothyroidism. Iodine deficiency, iodine excess, this is either in the form of like the patient may be taking iodine containing syrups or iodine containing foodstuff. Prematurity, a well-known entity where the child, if they are premature and they can have a transient phase of dysharmonogenesis, and then they can have improvement over the long-term follow-up. So blocking antibodies, particularly if the patient is having TRAB, and particularly this is quite commonly seen with Graves' disease in mother. If the Graves' disease is there in the mother, and then you have a child born to the mother with Graves' disease, you may find blocking antibodies initially for the first 3 to 6 months up to 1 year. This blocking antibodies will suppress suppress the thyroid gland, so that TSH will be high. Once the antibody titer comes down, your thyroid starts functioning again, so follow-up will be key. Antithyroid medications, overdose, which we find a lot. Even 2 days back, I had this patient with TSH of 98. The patient had been taking 10 mg of carbamazole over 3-4 years without monitoring. So this is quite commonly seen. We are supposed to counsel any patient with Graves' disease regarding this particular entity. Uncontrolled hyperthyroidism, there can be a transient central hypothyroidism, very rare, but we may need to refer this kind of patients where we tend to, we are not able to manage it clinically. Medications are very commonly seen. Steroids, we have amiodarone, we have lithium. So every possible, the drug history should be obtained whenever we are seeing an elevated TSH. Hepatic hemangiomas to cause this kind of a TSH to be higher. This is actually increased utilization of the thyroid hormone in the periphery, but very rare to have this kind of scenarios. Genetic mutations like DOX2 mutation, what we had seen from the neonate, definitely it is one of the least common entities what we see. So with this, I would like to conclude that though the thyroid means always permanent, but it's actually a myth. The thyroid is having a transient diseases as well. We need to recognize with investigation, use the investigation judiciously before stopping thyroid, reassess, and then only you are supposed to stop. So we need to do an ultrasound, we need to do the antibody profile. If required, the scintigraphy is also required before stopping and concluding that it's a transient disease. Thank you.